Okay. Good morning. As part of our series of faculty lectures from recent advances surgery, today we have a topic malignant melanoma and its management. This will be taken by Professor Utpal, who is Professor of Surgery at NRS Medical College. So I request Dr. De to please start.
Okay. Good morning, everyone. Thank you, Makunda, for allowing me to speak on this topic. Actually, if we look at this topic, malignant melanoma, it's a vast topic and it encompasses so many entities. And as you go through this subject, you will find that much of this subject, apart from us surgeons, it's related to biochemist, it's related to pathologist, molecular biologist. So, as surgeons, we have very little part to do apart from just nipping off the melanoma and in certain cases doing some lymphadenectomies. So, an understanding of this subject needs a very detailed understanding of molecular biology in that sense. But then discussing molecular biology right at this time is point of time is very difficult and is very vast. So I'll just go in through a brief mention about these molecular biology aspects, and then I'll tell what all we surgeons require to know as far as a malignant melanoma is concerned. Now, malignant melanoma is a very ancient disease, and it was known since the time of Hippocrates of Kos. And if you look it back into the history, it was initially thought to be a fungal disease. And at that time, what persons used to do was to just remove that black area which was found in the patient's body. Moreover, it was also found that there were certain group of individuals who actually had this disease in the families, running in the families. And this familial incidence or hereditary phenomena in malignant melanoma was known much before Mendel actually described his all his theories of inheritance. Now, malignant melanoma until the 1940s was basically a surgical disease where people or surgeons used to just remove the part which was involved. But later in 1940s, with the development of chemotherapeutic drugs, then and with the better understanding of the molecular biology concerned with malignancy, the whole management of melanoma has drastically changed. And now, as I am to speak about recent advances, but as I was going through the literature, I found out that most of the recent advances that have happened in malignant melanoma was in the field of molecular biology rather than in surgery. Now, in surgery, there were certain things which became very
Dr.
clear.
De, screen is not changing. Are you starting in the same slide?
Yeah. I'll
Okay,
continue to
okay,
the next
okay,
slide.
okay, okay.
So now, with the change of this strategy, nowadays most of the recent advances are usually in the molecular biology section. And whatever we find in the molecular biology, as you find in the this thing, the textbooks of surgery, we find that most of the changes are regarding the targeted therapies, regarding the what do I say, the chemotherapeutic drugs, regarding immunotherapy. So these are not part of our surgical treatment, though we have encroached in as in other subjects also, we have encroached much into the means the other areas where or the domain of other people. Now, coming to the brief, means I'll just give a quick recapitulation of cell cycle and the molecular biology behind this melanoma. So, if you look at the cell cycle, you will find that, as you all know, these are nothing new. The cell cycle consists of three phases, mainly G1, S, G2, and the M phase, and where the cell actually proliferates. And there are certain drivers like cyclines and CDK4s, which drive the cells through this cell cycle. And there are certain checkpoints, means during the development of the cell, the DNAs that they replicate, they could be either a normal DNA or an abnormal DNA. So there are checkpoints which usually detect these abnormal DNAs, and they discard the abnormal DNAs and the abnormal cells that are present in our body and prevent them from going into or from the cells to change into cancerous cells. Now, as we know that there are two types of, there are accelerators and there are brakes in the cell cycle. The accelerators are mainly the oncogenes and the brakes are the tumor suppressor genes. Now, coming into a brief details of the cell cycle. Now, this is if we look through into a bit details, we have certain growth factors which stimulate the receptors, and these receptors then what they do is they incite some mechanisms by which there is a down regulation of the signaling pathways which initiates replicative factors or transcriptional factors which usually act on the DNA to produce proteins which actually help for the cell growth and division. Now, why I have included this is because one of the most important factors of melanoma, formation of melanoma, as you all know, is the ultraviolet radiation. And this ultraviolet radiation, they cause changes in the receptors, they cause changes in the cell signaling pathways, they cause changes in the DNAs, and as a result of which there are abnormal proteins which are produced which inhibit the tumor suppressor genes, and also they stimulate the cell signaling pathways which usually results in formation of cancer cells. Now, if we this is a big recapitulation of neoplasia, and why this is so important is because melanoma is a one malignancy where you find all these 8 hallmarks of cancer with a distinct display. You find self-sufficiency, insensitivity to anti-growth hormone, evasion of apoptosis. But the important things which we are concerned with in melanoma and the current research or the current recent advances which are going on are the sixth, seventh, and eighth point. That is the ability to invade and metastasize, the reprogramming of energy metabolism, which is also known as Warburg's phenomena, and the evasion of immune system. Now, of which evasion of the immune system is the most important thing which scientists have discovered, and most of the recent advances are focused around this entity. So Warburg's phenomena, as you know, is an important. Why I have included it is because if you look at the TNM classification of melanoma, you will find that in the TNM classification, uh, uh, the in the M phase, we usually look at, apart from the metastatic profile, we usually look at the LDH levels. Now, if you remember the glucose metabolism, where glucose is converted into lactate, and then lactate converts into pyruvate and goes into an oxidative phosphorylation, here in the cancer cells, instead of going into the oxidative phosphorylation, there is what we say oxidative glycolysis. And now this is a modification which the cell does to decrease the amount of energy which is required for metabolism of glucose, and also so that the cell can work in an environment where there is less of oxygen. So these are some of the important things which I feel someone should have a good idea about before we go into the real topic of melanoma. Now, a bit about how melanoma develops. Actually, melanoma develops from the melanocytes, which usually sits in the basal layers of the epidermis, and these usually have an origin in the neural crest. Now, what happens is the keratinocytes, they usually produce a hormone which is known as alpha MSH, which is secreted from the anterior pituitary. They stimulate these melanocytes to produce what we call melanin. And these melanocytes, they have finger-like projections which usually transfer this melanin to the keratinocytes, and these melanin actually covers the outer surface of the keratinocytes, which shields the nucleus of the keratinocytes from the UV damage, means the damage by the ultraviolet rays. And slowly, as the keratinocytes they age, they become apoptotic, and they form a dead layer of keratinocytes over the skin, which usually protects the cells from the harmful effects of the UV rays. So this is a basic thing from where the melanoma usually develops, and these melanocytes are equal in number in all the individuals. It's not that the persons who develop melanoma have increased number of melanocytes. These melanocytes are basically, as you can see, there are 1,500 per square millimeter, and usually they divide twice a year. So, and what happens is these melanocytes, they have alpha melanocortin receptors. Now, these receptors are basically, they usually determine what kind of changes will occur. And these melanin, which is produced, maybe of two types. It may be a eumelanin or a pheomelanin. Pheomelanin is a melanin which is less darker than the eumelanin, and persons who produce, and these, whether it will be eumelanin or pheomelanin, is determined by the number of receptors which are present on the melanocytes, and any polymorphism in these receptors actually induce greater production of melanin, which actually prevents the person from developing a melanoma. Persons who have less number of MC1 receptors produce less melanin, and that is what is known as pheomelanin, and these persons are highly susceptible to development of melanoma when they are exposed to UV rays. So this is a basic background how melanoma actually develops. Now, as I was talking about the mutations, these are very important because melanoma can be of two types. One is a non-hereditary type, which usually results due to somatic mutation, and the other is a hereditary melanoma, which usually results from germline mutation. So, as I have talked previously, these germline mutations, these usually involve the tumor suppressor genes like P53, and also it involves germline mutations of genes which are involved in nuclear excision repair pathways, like xeroderma pigmentosa. So these are persons who are more susceptible to development of melanoma, and they have a melanoma which runs in the families. Now, what happens is these persons, they develop melanomas at a very younger age, and these melanomas are very aggressive also. So, but the incidence of these melanomas are 15 to 12%. Now, if you look at the total incidence of melanomas among skin cancer, it is only just 4%. But if you look at the malignant potential of melanoma, it's very high. So 95% of the patients, they usually have a high mortality rate. Now, coming to the non-hereditary or somatic mutations that occur in melanoma, now these patients usually have a mutation in the cell signaling pathway, which involves the MAP kinase pathway. This is the most common cell signaling pathway in the cells. Now, what happens, as I said, these signaling pathways, they have a mutation which is originally present, and a second hit actually occurs when these cells are exposed to UV rays. So that is what is Knudsen's two-hit hypothesis. Now the question is, why do we want to know in details about these mutations? The problem is melanoma is not a heterogeneous disease like other diseases. Means, what do I mean to say by a heterogeneous disease? Means all the melanomas, they actually behave in a different way from one another. And as such, the treatment that we offer to these patients does not fit into one size. So each of these melanomas have a different method of progression. They have a different tendency to metastasize, and so as such, they need to be individualized, and the treatment also need to be individualized for these kind of melanomas. Now, coming to the spread of these melanomas, if you see in this picture, you will find that this is a layer of the skin which is there, where when we find there is an epidermis, there's a basement membrane, and there's a dermis. So initially, these cells, as I said in the previous slide, that there are somatic mutations. Now, all these cells, the persons who are having these somatic mutations in the epidermis, all these cells are actually prone to develop melanomas, and persons who have a second hit in the form of ultraviolet radiation, either natural or artificial, as found in Western countries, then these cells, they turn into malignancy. And once they turn malignant, they have two types of spread. The one is the radial growth phase. If you see in the picture, you will find that it spreads horizontally along the epidermis but does not invade the basement membrane. The second part is some melanomas, they do not spread horizontally. They usually penetrate the basement membrane and go directly into the dermis. Now, based on whether they have a horizontal growth or a radial growth or a vertical growth, now it was long understood that melanoma was classified based on either the Breslau's depth or the Clark's level. Now, Breslau's depth means these are the anatomical compartments that the tumor usually transgresses, and the Clark's are the histological compartments that the tumor passes through. Now, Breslau's classification, as you will see later, are described in millimeters, and class levels are described by the histological compartments that the tumor transgress. But then these have created a lot of confusion, and later on, there was a consensus, and a TNM classification was devised now, which has universal acceptance, and the treatment is usually based on this classification. Now, apart from these, we have some morphological classifications as to how the melanoma looks, and this has been from traditional times been described in various textbooks. Now, if we look at the natural history of melanoma, what you would find is uh, the melanoma has got certain stages, and from a benign disease to a metastatic melanoma. And if you look at the biological events, you will find in the base there are biological events which occur as it transgresses from a benign lesion to a metastatic melanoma. And just beneath that, you have the molecular lesions which actually drive these benign lesions to a metastatic melanoma. So this is the natural history wherein a benign nevus turns to a dysplastic nevus, grows to a radial growth phase, and then a vertical growth phase until and unless it becomes metastatic. Now, these are the lesions which I was talking about. If you look at the Breslau's classification, it's usually the depth which is considered, and we consider these in terms of millimeters. And on the right hand side is the Clark's levels, as we say. These are based on the compartments of the skin that the tumor involves. Now, if you look at the morphological classification or the histological classification of the subtypes, as it's known as, we have the superficial spreading type, which is the most common. Then we have the nodular melanomas, the lentigo maligna, the acral lentiginous, the amelanotic varieties, and the desmoplastic lesions, which are around 4%. Now, if you look at the epidemiology, now this is very confusing. There are a lot of confusions regarding the demographics, the anatomical locations, and as you see, it varies from region to region. And the countries which are more prone to development of melanomas and who have got a good database of patients of melanoma have different demographic profiles compared to the ones who have lesser incidence of melanoma. So, though I have included this, but then there are a lot of variations. And as you see, the age bracket is 15 to 70 years. And as I said, it's not 50 to 70 years are those patients who have developed melanomas are patients who have somatic mutations, but those who have germline mutations or those who have a hereditary disease usually develop melanoma at a very younger age. Now, regarding anatomic locations, there are various theories. Means some say, as I have mentioned here, the thumb greater than the toe and the index finger. But the fact which should be remained is that melanoma is very common among in areas which are exposed to sunlight. Now, coming to the risk factors, as I have already said, UV radiation is the most important risk factor. It may be in the form of sun exposure or in the form of artificial UV radiation that usually people in the Western countries use to tan their skin. There could be family history of melanomas uh, and xeroderma pigmentosa, and there are certain syndromes where the people have increased incidence of benign nevus, and those they turn into melanomas. And immunosuppression is also one of the risk factors for formation of melanoma. Now, coming to the presentation, now this is a very interesting fact which I would like to point out is that melanoma may present in two types. It could be either a melanoma of an unknown primary or a melanoma of a known primary. What do you mean by an unknown primary? In an unknown primary, you find that patients present with a nodal disease, but there is no primary lesion which could be found. Why does that occur? Because, as I said, there are two types of squamous epithelium which lines our body. One is keratinized and the other is non-keratinized. But these non-keratinized epithelium also have melanocytes because they have a common site of origin, that is from the neural crest cells. So, de novo origin from an ectopic melanocyte, which results in the formation of an amelanotic melanoma, can give rise to a melanoma of unknown primary. Similarly, melanomas display a very unique characteristic of immune mechanisms which are very unique for melanoma. So sometimes what happens is if you see a histology of a malignancy, you will find that apart from the tumor cells, the malignant cells, the histology of malignancy usually shows increased number of either macrophages or T or immune cells. So what happens? These tumors, they actually incite the immune mechanism of the body. Now, due to excitation of the immune mechanism, three things can occur. Either the immune mechanism overtakes the malignant potential of the particular cell. And if the immune mechanism is able to tackle the malignant potential, then what happens? There is immune regression. Means what happens? The tumors, they regress. Now, this regression may be of two types. It could be a complete regression, in which case you won't find a primary lesion, or it could be a partial regression. Means the cancer cells, they are able to fight with the immune cells to a certain extent. Now, but when the cancer cells are starting to fight with the immune cells, the prognosis usually becomes poor, because those usually results means that is the stage when the tumor cells, they have acquired the ability to escape the immune mechanism, which is very unique in case of melanoma. And as the immune mechanism, as the melanoma cells, they escape the immune mechanism, what they do is they usually are detected and they might progress uninhibited. The other way is there could be an equilibrium between the malignant cells and the immune cells, and there a harmony exists, and we find that these tumors are usually moderately response has a moderate response to what are the targeted therapies or the immunotherapies that we usually give. Now, the other condition where we find a melanoma of unknown primary is our patients where resection has been done without a biopsy. So we often find patients coming to the OPD where they tell us that there was a lesion in the nail bed, the surgeon has excised it, and now they have developed lymph nodes. And on examination, we find that those lymph nodes, they show histopathology of melanoma. The other type of presentation is melanoma of a known primary. As I said, it could be of a melanotic variety or an amelanotic variety. Now, the melanotic variety may present as a primary tumor, and these tumors, as I said, the skin has all the cells have a potential to develop melanoma, and as such, a field cancerization effect is seen. And sometimes also these cells, they show a collusion or contagious phenomena, means that they all these cells, they have a potential to change into two distinct cell population, and as such melanoma may present with other skin cancers like basal cell cancer. So now coming to the clinical presentation, I think this is a quite known subject, and this is universally used, and it is basically a subjective description and depends upon a visual impression of the observer. And as most people, and this is a universal mnemonics by which we usually determine, that is the A, B, C, D, E. which includes the asymmetry, the border, the color, the diameter, and the evolution. But then there are certain melanomas which do not show these kind of characteristics. That is, those are the melanoma in children, the subungual melanomas, and the nodular melanomas. So whenever we have these A, B, C, D, E, if there are more than two of these features, the person should be subjected to biopsy. Now, the other clinical presentations or the visual impressions based on which a clinical diagnosis is made includes a 7-point checklist, which includes certain major signs, certain minor signs, and then depending on how many major, that is, if there is one major and 3 or 4 minor signs, these patients are subjected to biopsy. Now, the other thing is an ugly duckling sign. So, as I said, that the persons who have a single hit are prone to develop some benign nevus. Now, of these, they have multiple benign nevi or multiple moles all over the body, and then suddenly there is a second hit, and one of these moles they start changing. Now they start developing by development of fissures, as can be seen, or there is a thinning of the epithelium covering that particular lesion. So that actually stands out against the other nevus, and that is what is known as the ugly duckling sign. So these are the visual impressions based on which we usually diagnose a melanoma. Now, biopsy, as I said, these patients are subjected to biopsy, and but then, though having said that biopsy is diagnostic, but if you look at the recent literature, it is very difficult to diagnose a melanoma of biopsy because the lesions or the cells, there are so many mimics of melanoma that it's very difficult to say whether a cell, particular cell, is a malignant cell or a benign cell. Moreover, biopsy cannot specify actually in terms of specificity as to what morphological type of melanoma the patient has developed. Still, the more we have these four types of biopsies which we usually perform: the excision biopsy, the incision biopsy, the punch biopsy, and the shave biopsy. Now, excision biopsies are done in lesions which are less than 1.5 centimeters and which does not cause enough disfigurement or does not cause any aesthetic change. And for an excision biopsy, we should take a 2 millimeter margin. Now, the preferred methods are the incision of the punch biopsy, where a full thickness biopsy right up to the dermis is taken and the depth of invasion can be said. Now, regarding shave biopsy, I put in a big cross there. Shave biopsy should not be done, but actually, if you look in the current literature, persons are preferring a shave biopsy because it's easy to do and it's anyone can do it, and actually, we can have an idea about whether that lesion is malignant or not. But more or less, an incision or punch biopsy are the biopsies which should be done. Now, as I said, that biopsy is not very much diagnostic. So, like other tumors, molecular markers are very much important to make a specific diagnosis of melanoma. And there comes the question of heterogeneity. Because until and unless we diagnose what kind of melanoma it is, we need to give targeted or immunotherapies, it becomes difficult. So there are certain diagnostic markers which are also known as melanocytic markers, and there are certain prognostic markers or proliferative markers. Now, as regards other malignancies, also there are certain rule-in markers, means these are sensitive markers. Now, these markers say that it's a melanoma, but then it cannot say definitely as to what type of melanoma it is. Now, these diagnostic markers are in the form of S100 or SOX. There are a host of other markers also which are there, but I have just put in two of them. And now the important thing is the rule out markers, which are very specific markers, and these actually point out to actually what type of melanoma has developed. And these include melanin A, MERT1, HMB45, and also there are many. These are panels actually, and based on those panels, which is positive, we actually assign that this kind of melanoma is present in this patient. Now, this is important when we take into account immunotherapy or targeted therapy for melanomas. The other is a prognostic or proliferative markers. Now, these are very common, the Ki67 and the PPH3. Now, these are nothing but these are certain markers which usually tell us how fast the cell is dividing. Now, as I said about Warburg's phenomena sometime before, there are certain metabolic changes in the melanoma cells, and the melanoma cells actually switch on to aerobic glycolysis rather than oxidative phosphorylation. And when the cell switches to an aerobic glycolysis, the LDH, that is conversion of glucose from lactate to pyruvate, involves this enzyme LDH, which increases its function. So in aerobic glycolysis, the LDH enzyme is raised, and this is one of the serological markers which tells us about how fast the cells are growing. So this is a serological marker, and if you look at the when I talk about the metastatic profile in the TNM classification, you will find that LDH is an important component which is taken into account. And now having said about biopsy, this is one of the newer approaches which are coming into means use nowadays. These are the non-invasive imaging techniques which actually guides the physician as to the lesions which need to be biopsied. So these were in the initial stages, these were of not much significance, but with the development and with the development of technology, it helps us as an adjunct to visual screening. It helps us to decide whether biopsy is necessary or not. It aids to find out the ugly duckling, as I said before. And of the non-invasive imagings, the most common are the MELA-FIND and the SIS scope. Now, regarding this Melafind and SIS scope, they actually, what they do is they use the spectrophotometric or infrared light, and they usually determine the depth as to which the cells have invaded. And if we have a suspicion on non-invasive imaging, we usually subject those patients for a biopsy and immunohistochemistry. Now, of these two that I have written, the most commonly that is used is SIS scope because it is very easy to handle, and moreover, it's more sensitive and specific. Now, coming to the spread of melanoma, melanoma usually spreads by three routes. The most common of these are the lymphatic route, the hematogenous route, and the iatrogenic route. Now, if you look at the lymphatic spread, now there are certain important aspects which need to remember when we talk about lymphatic spread. One is the satellite nodules. What are these nodules? These are nodules which are less than 2 centimeters from the primary tumors. So if we have a primary lesion and we have a second lesion which is within 2 centimeters, then we say it's a satellite lesion. Now, in-transit lesions are lesions which usually are more than 2 centimeters away from the primary tumor, but they fall in the line of the drainage of that primary tumor to the nearest lymphatic basin. There can be regional lymph nodes also, which may be involved in melanoma. Hematogenous spread is also been found to be present in melanoma, and the classic way in which we can say that hematogenous spread is occurred because is by telling that even when we put in a split thickness screen graft, those sites also have developed melanoma. So that is a proof that hematogenous spread also occurs. Now, the other mode of spread that has been talked about is the iatrogenic spread, but this is not of much importance. Now, coming to the staging, I won't go very details into the staging aspect because if you look at the staging, for mainly for the, I'll tell you what are important as far as T is concerned, what are important as far as N is concerned, and what is important as far as the M is concerned. But just have a look at the different means depth of invasion that is included in the T stages and whether ulceration is present or absent. So that is taken into account when we T stage the tumors. Now, coming to the end stage, then there are certain important aspects which I'll discuss also later, but just keep a note of it. That is the sentinel lymph node biopsy. When we are to do a sentinel lymph node biopsy, what are satellite nodules, whether they are present or not. So based on this, we have this end staging. Now, basically, as a general surgeon, means I fear oncologists because of these stagings, because I'm a very poor memorizer, and seeing at these staging, it really scares me. And so I did not put in much effort to remember this, apart from looking at the textbooks. But means it's better. Because as surgeons, if you have means wherever there are high volume centers dealing with it, they have got their own charts for this staging. And if you have a developed technique of making charts and then use it on a regular basis, I feel it becomes very easy. Now, coming to the metastatic disease, you'll find, as I said, LDH is one of the important components which is included in the metastatic disease when we classify or stage melanoma. Now, what I was speaking about, what are the important aspects in the staging? In the tumor staging, we consider about tumor thickness, we consider about ulceration, and the other aspect we take into consideration is mitosis. Now, coming to the end stage, we take into consideration the number of lymph nodes that are involved, whether the lymph nodes are clinically palpable or not. If the lymph nodes are clinically palpable, we perform an ultrasound and subject those lymph nodes to fine needle aspiration cytology. Now, for clinically impalpable lymph nodes, like other tumors, as in breast, we perform a sentinel lymph node biopsy. But then there are certain limitations or indications when we do a sentinel lymph node biopsy. A sentinel lymph node biopsy is usually indicated when the tumor is more than 1 millimeter, or when the tumor is zero point 0.7 to 6 to 1 millimeter, but the, these are present in a high risk group. What is high risk? High risk means when there is lymphovascular invasion, when there is a high mitotic count, when there are ulcerations, and there is a family history. Sentinel lymph node biopsy per se is not done in lesions which are less than 0.76 millimeters. Now, metastatic workup is more or less the same as for other solid tumors. For early stages of melanoma, we do not require metastatic workup, but for the late stages, we need a metastatic workup, and that includes a host of investigations which are available for other solid tumors also. Now, if you look at the current guidelines of performing a sentinel lymph node biopsy, now all these associations, they have their own guidelines. The ESMO has a particular guidelines for performing the sentinel lymph node biopsy. And if you see the timings of development of these guidelines, you'll find that they have evolved from 2012 to 2017. But the guidelines which are currently followed, as I have said, are the NCCN guidelines which I have described before. So, coming into the summary of the TNM classification, the stage 1 and stage 2 are, it depends upon the vertical depth of the invasion and where there is no distant or nodal metastasis. Stage 3 is progresses to gross or microscopic lymph node metastasis, and stage 4 when there is evidence of distant metastasis. Now, the staging is important because we need to know what we have to do for each stage of this disease. Now, coming to the management strategy, once a melanoma is diagnosed, the first is we do a biopsy, and then we do a pathological confirmation. And if it is a melanoma, which is in the carcinoma in situ stage, we do a wide margin excision, taking a 0.5 centimeter margin. For tumors which are in the T1 stage, we take a wide margin of 1 centimeters. For tumors which are from stage 1 to stage 4, but if there are no lymph node or metastasis, then for stage 2, we take a wide margin of 1 centimeter, and for 3 and 4, a 2 centimeter margin is taken. But for stage 2 and above, we usually perform a sentinel lymph node biopsy, even though lymph nodes are not positive. And if the sentinel lymph node biopsy is negative, we usually follow up. But when the sentinel lymph node biopsy is positive, then we do a ultrasound-based follow-up or a lymphadenectomy. So there are various what do I say? There are various ways in which people look at it. But some people, I'll come to it a bit later. People usually follow up or they do a lymphadenectomy. Now, for any C or N, we do a wide margin excision with a lymphadenectomy. Now, for advanced tumors, we do either we give a chemotherapy, or we do an immunotherapy, or we do a target therapy. Now, if I have divided this into three stages. Now, this is what is important for surgeons: surgical treatment of a localized disease. So, this is the best option which can be done for a melanoma, considering that if the disease becomes metastatic, the prognosis is poor because we have limited options. So, earlier we diagnose and treat, it's better for the patient. Now, wide local excision is the current standard of care for these melanomas, and means it's quite a subject which is debatable, because what means by a wide excision compared to an excisional biopsy, that is a subject of debate. Now, excision, when we do, should extend down to the level of the underlying muscular fascia, so that we take the whole thickness of the skin when we are excising the lesion. Now, if you look at the recommended margins for surgical excision, these are the recommended margins, and you would find these in any standard textbooks. So, for an in situ lesion, it's 0.1 to 1 centimeters. Lesions which are less than 1 millimeter, a 1 centimeter margin. For 1 to 2 millimeter lesions, we have a 1 to 2 centimeter margins, so on and so forth. Now, this is one of the surgeries which were practiced before also, but we do it sometimes. It's done nowadays also. This is Mohs micrographic surgery. So here, what we do is we stepwise tangentially excise the specimen till we appear or come to a normal appearing skin. But the problem is we need to have my pathologist by this side, so that we do an immediate microscopic examination of the entire surgical margin. What is the advantage? Advantage is a tissue sparing procedure. So wherever there is a melanoma which might lead to a cosmetic defect, we can try out this. But it has got a very more of the disadvantages than the advantages, because there are pathological difficulties which one might encounter as far as diagnosis is concerned. Because I said that, as I said earlier, that these melanoma cells usually have certain mimics which usually mimics these lesions. So, considering the disadvantages of this type of surgery, it's no more an acceptable modality for invasive melanomas. Now, what do we do for clinically negative regional lymph nodes? So, as I said, we do a sentinel lymph node biopsy. Now, current standard therapy for patients with positive sentinel lymph node biopsy is to remove all the involved lymph nodes. So, we do a regional lymphadenectomy. Now, now there was a study, as you see, a DCOG SLT study, which usually said that if there are micrometastases which are less than 1 millimeter, or sentinel lymph node disease was present, actually there is no survival benefit comparing to nodal observation versus completion lymphadenectomy. Means survival benefit means the patient actually has a long-term survival benefit, but melanoma specific benefit is not there if we do a lymphadenectomy. Now, if there are other studies also which were done. Now, for clinical negative lymph node, there were two important studies. One was the multicentric selective lymphadenectomy trial, and two trials were made. And the first trial compared sentinel lymph node with elective lymph node dissection, and the second trial they compared sentinel lymph node dissection with completion lymphadenectomy versus sentinel lymph node positive and a follow-up. Now, if you look at the results, what you will find that when we do an extensive surgery of lymph node clearance, it improved the long-term disease-free survival and has a good loco-regional control, but it did not improve the melanoma specific trial. So coming to that, so there is a lot of confusion in this area, but still what we do is, if we have a sentinel lymph node positivity, then we usually try to clear the lymph nodes. Now, the elective lymph nodal dissection, as I said, there are two groups of followers. One, they say that we do a prophylactic lymph node dissection or an elective lymph node dissection, but then there are certain objections to it, because in a stage 1 disease, there are 20% of patients who develop these sentinel lymph nodes. So, without doing a sentinel lymph node, if we clear or do an elective lymph node, we actually harm 80% of the patients by the complications that usually occur due to that lymph node dissection. And moreover, the elective lymph node dissection does not show any survival benefit. So, elective lymph node dissection has now been replaced by sentinel lymph node dissection. Some say we do a sentinel lymph node dissection, we follow up the patient, and if the patient develops a recurrence, then we do a delayed lymphadenectomy. Now, for clinically apparent regional lymph nodes, we can do a therapeutic lymphadenectomy, means depending on the area, whether it is an inguinal or an axillary or a cervical, we do a lymph node dissection accordingly. Now, this is one of the important aspects which we need to know about the loco-regional therapies for melanoma. So, the loco-regional therapies which are available for melanoma are the surgical treatment, but then these are done for selected cases where the melanoma has not invaded deep and is amenable to surgical excision. Apart from that, we can use a regional chemotherapy in the form of either an isolated limb infusion or an isolated limb perfusion. Now, these are two entities which are different from one another. In isolated limb perfusion, we usually use a chemotherapeutic drug, usually melphalan is used at a higher temperature, and we isolate that limb from the vascular supply of that limb from other areas of the body by means of a tourniquet, and then we infuse the lesion, the chemotherapeutic drug, at a higher temperature. In isolated limb infusion, actually, the same thing is followed, but then at a higher temperature is not used, and the infusion rate is very slow. Now, but if you see at the response rate, you find that the response for isolated limb perfusion, the response is much higher than the isolated limb infusion, which is only 64%. But then considering also having said that it has got a higher response, but if you look at the grades of toxicity, which you will find in the recent advances, I haven't included this, the grade toxicity is grade 5 toxicity, which develops with ILP. So that is the main disadvantage of isolated limb perfusion. That is why the concept of isolated limb infusion has come. But if you look at the cure rates for ILI, it's quite less compared to ILP. Now, there are a host of intralesional therapies which are coming up. And if you look in the literature, you have in your recent advances three of them. That is, one is TVEC, then there are interleukins, and there are others. But if you look up in the literature, so this is the area currently where research is going on. But I felt that TVEC should be mentioned because, see, it's very difficult for me to pronounce actually what is the whole thing. So TVEC is what it is, a attenuated virus which actually helps, that is a herpes virus, which actually, what happens, it's an attenuated virus which actually does what, it stimulates the immune mechanism of the cell so that immunity can destroy the tumor. More or less, this virus has got a capacity to do or to create immune lysis, that is, destroy the tumor cells by themselves. Now, there are other therapies which are there, but these are mostly, the other therapies are meant for metastatic melanomas. So, what do we do for a metastatic disease? For a metastatic disease, we can do a surgical metastectomy, but that too also in selected patients, as I mentioned, if the metastasis is low, means the numbers are less, and it is amenable to surgical treatment, then we can do a surgical metastatectomy, because surgery is more the rest is the definitive treatment. If we can do it, that has got the best prognosis. Now, chemotherapy can be done with the means of either melphalan or dacarbazine. Now, melphalan has got a higher toxicity rate compared to dacarbazine, but then these chemotherapeutic drugs does not work for a pretty long period of time, and soon the melanoma cells, they develop mechanisms whereby these drugs, they become resistant. So, based on this, then these newer therapies have come up. These are targeted therapies. Now, there are certain therapies which usually work within the cell, that is in the cell signaling system, that is the BRAF, and you have different names for it, vemurafenib, dabrafenib. So these are certain target therapies which are available. These are newer forms of therapies which are coming up. And last but not the least are the immunotherapies, where we need to give some therapeutic vaccines which differ from prophylactic vaccines, because therapeutic vaccines, they all these actually stimulate the immune system of the body, and they actually try to destroy the melanoma cells. We have adaptive cell therapy in the form of immune checkpoint inhibitor. Now, this is another vast subject of its own. Means I'll just mention you in brief what it happens is there's melanoma cells actually, they have some immune evasion mechanisms whereby these are that is CTLA and PD1 are certain receptors which are utilized by these melanoma cells to evade the immune mechanism. Now, if we block these receptors by antibodies, then what will happen? The dendritic cells or the T lymphocytes, they would attack the melanoma cells and then kill those cells. So these are newer forms of therapy, and the immunomodulator, interleukin 2 mainly, which increases the melanoma specific T lymphocytes. So currently, all the research that is going on in melanoma is focused on this last aspect, that is immunotherapy, which I feel is beyond our scope of knowledge. And then once we have performed surgery, definitely, if these therapies have is an adjunct to our surgical therapy and prolongs the life means disease-free melanoma survival, that would be of much benefit to the patients. So, to summarize, melanoma is an aggressive skin malignancy of melanocytic origin. The condition uh, the condition is typically seen in patients 50 to 70 years of age, and they present with pigmented lesions with a recent change in shape and size. Diagnosis is made with a biopsy showing melanocytes with marked cellular atypia with invasion into the dermis, and treatment is actually wide local excision. So thank you for your patient hearing, and this is what I had to say about melanoma. I think I could describe in brief because this is a vast topic, and whatever I felt is important for you, I could describe. And if you have certain questions, you can ask me, or you can get my mail and ask me. I would be very happy to answer those questions. Thank you so much.
Thank you, Dr. Dev, for a nice coverage. This is an exhaustive coverage. It's adequate for a, PG to answer a theory question even. And a few things are that these melanomas, once you have a case in the exam, don't try to give a TNM classification on clinical examination, because this TNM staging is based on the result of the biopsy also. So you just diagnose melanoma, but don't try to give as a T1, T2 or whatever lesion, because this includes some other points in biopsy. So there are some malignancy now that you cannot give a TNM staging based on your just clinical examination. And another thing is LDH is very important marker, but to keep in mind that LDH is again not very specific. LDH is a marker of rapid cell division, and this can be present in other malignancy also. So anybody has any question in the, you can put the question in the chat box. What about tumor markers? Yes.
I have described certain tumor markers. See, I have said, if you have followed my slide, I have said that after biopsy, we do an immunohistochemistry. And then we have certain tumor markers which are rule-in markers. Rule-in marker means what? These are tumor markers which are shown by most of the melanoma cells. But then we cannot specifically attribute these tumor markers to a particular melanoma. So we need to have some rule out tumor markers. But I feel that means in your textbook you will find I have mentioned a few of those, but melanoma has got hundreds and thousands of tumor markers. So I don't think it is very important for you to remember each and every tumor marker. But then if you ask me certain for BRAF, we have a tumor marker which is V600. So that is one of the important tumor markers. Then we have some tumor markers which are very specific to tumor suppressor genes. So these are certain tumor markers, but I don't ascribe too much importance to these tumor markers unless until you become a melanoma specific surgeon. So I think there's a panel of tumor markers.
Yeah.
You can go through the textbooks. So that is it.
Okay. Thank you, Dr. De, for the nice coverage of the topic. Thank you very much.
Thank you, sir.
Thank you.
Thank you.